வெல்கம் டு டீ கடை பெஞ்ச். இன்னைக்கு ஒரு இன்ட்ரெஸ்டிங் கேஸ் ஸ்டடி பற்றி நம்ம டாக்டர் கூட டிஸ்கஸ் பண்ண போகிறோம். ஸோ லெட்ஸ் மூவ் ஆன் டு த கொஸ்டின். குட் மார்னிங் சார்.
குட் மார்னிங்
சார். ஒரு 20 years old male patient presented with the complaints of breathing difficulty and severe itching all over the body following the consumption of crab.
Okay.
So how we differentiate simple allergy from anaphylaxis, sir?
That is very paramount because sometimes we are in a very toughest position to differentiate between whether it is a mild allergic reaction or whether we are dealing with anaphylaxis. Generally, anaphylaxis consists of few more added things apart from your mild skin allergic reactions. Any simple allergic reactions may involve intense pruritus all over the body. Probably you may have swelling of lips or mild facial edema. But any systems involvement, definitely that may point out the diagnosis of anaphylaxis. So anaphylaxis generally, they have postulated many guidelines and criteria, but generally anyone who presents with intense pruritus over skin, then you have hives and a lot of urticarial lesions, and you will have cutaneous, apart from cutaneous lesion, you will have mucous lesions also, like including swelling of lips, and you will have facial edema. To some extent, they will have even laryngeal edema and uvula and everything, so on. So the most important thing is, apart from this mucus and cutaneous lesions, what you have to remember that there may be one of the systemic involvement. For example, when it is involving the lungs, respiratory system, and there will be signs and symptoms of respiratory compromise. Many of the victims, they used to complain, they will have some kind of lump in the throat. So I have witnessed many cases, they used to complain lump in the throat, and they will try to clear the secretion from the throat. These are the earliest symptoms for which they used to attend our visit. So what they initially complain, after exposure to particular antigens, so what happened, they will have some kind of they want to clear some kind of secretion from the throat, lump in the throat, some kind of compression over the throat, then followed by they will complain obvious breathing difficulty. That will be evident, much wheezing on auscultation. They may present with stridor, and if you check the saturation, probably less than 94%. So these are some kind of signs that will tell us there is some kind of respiratory compromise apart from mucosal and cutaneous lesion. Then one more system that is commonly involved is cardiovascular system. So they will present with blood pressure less than 90 mmHg. Sometimes those who are hypertensive, sometimes many patients may be a known hypertensive, but they generally they may not be on any medication. They used to maintain blood pressure around 190. So how we can say hypotension in this individual? So when they are known to have maintained very high blood pressure, then probably if there is 30% reduction of blood pressure from their baseline, for example, somebody is maintaining 180 mmHg systolic blood pressure, okay? Suppose 1/3 of 30%, so 30% of BP reduction means 180, somewhere around 60. So if you deduct that 60 from 180, so 120. For them, even 120 mmHg also you should take it as a hypotension. So not necessarily less than 90. Those who are known to have high blood pressure, then probably 30% reduction from the baseline also should be considered as hypotension. So either involvement of respiratory system or involvement of cardiovascular system in the form of hypotension. Sometimes they present with frank syncope also. So apart from that, they may have some kind of abdominal cramps and vomiting secondary to intestinal edema. So apart from cutaneous and skin lesion, if they have systemic involvement either in the form of respiratory compromise, then cardiovascular system, I mean hypotension, then they will have persistent abdominal muscle cramps and persistent vomiting and pain. Then all may point out that you are dealing with anaphylaxis. So that's the way definitely you can differentiate between the mild allergic reaction and the anaphylaxis. So anaphylaxis, we used to say it is a type 1 hypertensive hypersensitivity reaction basically.
Okay, sir. So what are all the substance which can trigger anaphylaxis, sir?
See, the points to be remembered is any substance can produce anaphylaxis. That's the thing we used to say. Any person can develop allergic reaction to any substance at any time. So this is the rule. So you can't say that whether the patient can develop anaphylaxis secondary to peanut or fish or crab. So in that case study, the patient developed anaphylaxis secondary to crab. So crab we have been witnessing, but sometimes even peanut or peculiarly one patient told me after consuming rice she used to have hypotension and intense pruritus. So it is very difficult to say that which substance is capable of producing a type 1 hypersensitivity reaction or anaphylaxis generally. Even 7 years before, after administration of first dose of insulin, patient developed anaphylaxis. So it is always it is prudent that better to ask any history of past history of allergic reaction or any family history of allergic reactions. That would be giving lot of clues regarding their potential to develop allergic reactions.
Okay, sir. So when we suspect anaphylaxis, what we are supposed to do, sir?
So once you suspect anaphylaxis or when patient is diagnosed to have anaphylaxis, the first most important is you have to assess the patency of the airway. First, always we used to say ABC, airway, breathing and circulation. That is also applicable here. Once patient comes to us, if patient has breathing difficulty and dyspnea, check saturation. Okay, if it is more than 94%, well and good. If it is less than 94%, then you just keep oxygen. Otherwise, if respiratory system is very much compromised in the form of tachypnea more than 30, then if patient develops saturation less than 90%, then when you witness the involvement of accessory muscle respiration, or if patient is going for gasping, I think that patient needs intubation and mechanical ventilation. But the most important that once you are convinced that airway patency is good, to some extent you can manage without any intubation. The most important drug that should be given is injection adrenaline. So generally, as a practitioner, we have so much reservation to give injection adrenaline considering the tachycardia secondary to adrenaline administration. But what you have to remember that withholding the treatment, I mean withholding the administration of injection adrenaline would be very dangerous than administration of adrenaline. So when you suspect anaphylaxis, suppose patient is in hypotension, BP is around 80 or 70, there is some amount of respiratory compromise, without hesitation, you have to give injection adrenaline in no time. So basically, injection adrenaline is available in 1 in 1000. So whatever available ampoule is 1 in 1000, that is available as 1 milligram in 1 ml. So you have to take 0.5 ml. That 0.5 ml of injection adrenaline can be given in the anterolateral part of the thigh. You can give intramuscularly. So once again, I want to repeat it. The available adrenaline is 1 in 1000. You don't need to do anything. You don't need to dilute or anything. Take adrenaline from the ampoule that is available as 1 milligram in 1 ml. You require only 0.5 milligram. That means you have to take 0.5 ml from the ampoule, then give as intramuscular route at anterolateral thigh. Okay. Suppose after giving adrenaline, you just wait for 5 to 10 minutes. Still patient has hypotension, blood pressure still 70 and 80. There is not much improvement in blood pressure or respiratory compromise, then you can repeat one more intramuscular dose also. So you can give one more intramuscular dose, again 0.5 milligram, I mean 0.5 milligram or otherwise called 0.5 ml from the ampoule can be given intramuscular route. Then you just wait for 5 to 10 minutes. Still patient not yet improved, then one more IM injection also can be given. So 5 to 15 minutes once, maximum 3.5 milligram injection adrenaline can be given in a row. That's very, very important. Suppose a patient has very much, you are not able to record blood pressure, patient is quite breathless, okay, at the verge of intubation, then probably you can use injection adrenaline as an IV route. But the thing is, IV route you can't give 1 in 1000 dilution that is commonly available in ampoule. So what you have to do, the commercial available adrenaline is 1 in 1000, but for IV you have to make it 1 in 10,000. So what you have to do, that 1 ml injection adrenaline to be taken out from the ampoule, that 1 ml has to be diluted with 10 ml normal saline, then you have to give that 5 ml. So you have to give 0.5 milligram injection adrenaline, but 1 in 10,000 dilution. As I told you earlier, it has to be diluted something like that. Then you have to give over 5 minutes. So always try to give injection adrenaline when you suspect anaphylaxis, which involves respiratory system and cardiovascular system. But generally, when you have some kind of reservation, then probably you may lose the patient also. But you don't have adrenaline, then you can refer the patient. But when you have adrenaline, but when patient has impending signs of anaphylactic shock, then don't hesitate to give injection adrenaline, either IM route or IV route, means it has to be diluted in 10 ml as 1 in 10,000 solution. Then apart from that, we used to give steroids and H2 blocker, but generally steroids have much limited role in the management of anaphylactic shock, because you know very well that the anaphylaxis means there is release of histamine from the mast cells. Okay, so the mast cells that is present in the respiratory epithelium. So once allergen is exposed to our IgE, this IgE and the antigen complex causes release of histamine from the mast cells. So what happened? Histamine causes enormous vasodilatation all over the body, especially all the peripheral blood vessels are disproportionately or inappropriately dilated, resulting in pooling of blood in the periphery. So what happened? All the blood is shifted to periphery rather than to the central organ. So what happened? There will be ischemia to the central organs, namely brain and heart, liver and kidney. So this is called distributive shock. You know there are 4 types of shock. One is hypovolemic shock. Yes, you are aware of that. And another one is cardiogenic shock. And third one is distributive shock, where what happened? Because of histamine release secondary to this allergen, what happened? All the peripheral arterioles will be dilated. So all the blood will be dilated to the periphery. What happened? All the main blood vessels are compromised. That is called distributive shock. So please remember that steroids are not capable of preventing histamine release from the mast cells. That is very, very important. Why we prefer adrenaline over antihistamine and steroid? The most important thing is adrenaline is the one that is capable of preventing histamine release from the mast cells. That is the basic pathophysiology behind the anaphylaxis. So that's why your steroids and antihistamines may be playing an additional role, but steroids one another way it may be very useful, because most of the anaphylactic reaction is biphasic reaction. We used to say what we mean biphasic reaction means, once patient presents with anaphylactic shock, after giving injection adrenaline, after resuscitation of the patient, after 8 hours of the episode, patient may develop one more episode of allergic reaction in the form of hypotension, breathing difficulty. That may happen in 5% of the individual, but that delayed reactions can be prevented by administration of steroid. That's why along with adrenaline we used to give steroid, but generally steroid we prefer hydrocortisone, can be given 200 milligram very easily. Then if you want to give methylprednisolone, that should be given like 125 milligram to 250 milligram, not 40 milligram, because 40 milligram methylprednisolone is an anti-inflammatory dose. It is not basically it is not an immunosuppressive dose. So that you have to remember that. Then you can give antihistamine. That's why we prefer chlorpheniramine, Avil we are giving IM. And in fact, even you can give H2 receptor blocker, even ranitidine also plays a role, because many literature says that these allergens sometimes react with H2 receptor as well because of cross reactivity. So even ranitidine may be helpful. So apart from injection adrenaline, you can give steroids and antihistamine. And for hypotension, very very important, when somebody present with 60 or 70, patient has to be resuscitated with generally crystalloid, preferably 0.9% normal saline, because 0.9% normal saline is the fluid of choice in resuscitating the shock. Generally, any adult patient you can give 1 to 2 liters very liberally. Suppose if it is in a pediatric age group, then probably you can calculate in such a way that 20 ml per kg. For example, somebody weighs about 30 kg, then 30 into 20 is 600 ml. So this resuscitation can be repeated every half an hour, 1 hour, based upon your blood pressure. But otherwise, any adult patient deserves at least 1 to 2 liter of normal saline. Now you have addressed cardiovascular compromise and respiratory compromise with injection adrenaline. To prevent delayed reaction, we give steroids, to some extent antihistamine. Then to resuscitate shock, we are supposed to give 0.9% normal saline. So this is the overall treatment. Suppose if they have extensive wheezing, you can give beta 2 agonist in the form of nebulization as well. So bottom line of this case presentation is, don't hesitate to give injection adrenaline 0.5 ml, that is available in ampoule, that should be given 0.5 ml IM if you suspect anaphylaxis.
Thank you, sir. Thank you for all your wonderful explanation. So, what we have learned today, we should not hesitate to give injection adrenaline 0.5 ml when we suspect anaphylaxis. Thank you.